Good afternoon, everyone. Good afternoon, everyone. So I'm Zelia Oboshi Ago, and I especially welcome you to today's CPD, virtual CPD. Hello, good afternoon, everyone. So I'm Zelia Oboshi Ago. I'm a pharmacist and then a medical representative with Servier Pharmaceuticals. And I especially welcome you to today's virtual CPD. And today's virtual CPD is on the need and clinical use of a triple drug therapy based on ACE inhibitor. And today's CPD will be in three sections. And to facilitate the first session is a senior cardiologist and senior specialist physician. He's also a senior lecturer and a part-time lecturer and a clinical examiner at the KNUST SMS and also at the University of Cape Coast School of Medicine. So I humbly welcome you, Dr. Lambert. Dr. Lambert Tete Apia, please have the floor. Thank you.
Thank you very much, Zelia, for the kind introduction, and I welcome every one of us to this afternoon's program. As has rightly been mentioned, we want to look at single pill combination therapy for management of hypertension. And these are my disclosures, and what's on menu for this afternoon is basically a bit of introduction, the guidelines, then we will talk about some data available for single pill combination therapy going forward. So indeed, high blood pressure, it's the number one risk factor globally, and in Ghana as well, as you can see from this data. It is a leading cause of mortality and even morbidity. We have over 1 billion adults between the ages of 30 and 79 who have hypertension. The sad story, though, is almost half of these patients with hypertension are unaware. Excuse me, can I be heard? Am I audible? Okay, great. So, as I've mentioned, almost half of these patients with hypertension are unaware, and that is a great source of concern. And even out of those who know they are hypertensive, a little over 20% have their blood pressures controlled. So we have a huge burden, almost half who are not aware, and even for those who are aware, only about a fifth of them are controlled. So it's a big issue we have on hand here. As you can see from this graphic, Ghana is within the 34% and over, and there's data available both in Ghana, which both presenters today were fortunate to be part. So as you can see, hypertension is 40% in our population, and these were individuals who were just assessed routinely in the community. So these are not patients who presented to the hospital. These are apparently healthy individuals. The projections are quite grim, as you can see. Africa is expected to benefit from 100% or more rise in the burden of hypertension, and it's, I dare say, the worst of all the projections across continents. So there's a lot of work to be done. It's the number one risk factor. Every 20 millimeter rise in systolic blood pressure comes with it attendant increase in relative cardiovascular risk. So as you move from 115, 135, to 155, the numbers begin to exponentially increase, as you can see. So clearly, an increase in high blood pressure comes with an increase in cardiovascular risk, and it's no respecter of ages. As you can see, between 40s and 80, as you go up systolic or diastolic, your rate of ischemic heart disease goes up. So this burden has clearly been studied, and guidelines have come up. So we are looking at the 10 commandments of the 2018, which is the latest European Society of Cardiology guidelines. Then they came up with what we call 10 commandments of hypertension guidelines. So there is a lot of clarity in terms of the cutoff point, depending on if you are in the office. So a traditional 140, 90 cutoff, and if you are doing a home BP or home blood pressure monitoring, then that is, as you can see, cutoff is 135 and or diastolic of 85 or more. And this is comparable to the daytime blood pressure if you used an ambulatory blood pressure monitor. So these are the cutoffs for the European Society of Cardiology. It's important that blood pressure is measured correctly. So you need to be not talking, sit upright, your back supported, your feet on the floor. You need to be off any caffeine medication, any smoking, 30 minutes before. You need to have emptied your bladder. You need to have relaxed 3 to 5 minutes. And then you need to take at least 2 to 3 measurements, and you can throw away the first one and at least average the last two, so that it's a bit more reliable. And you can see that the arm has to be close to the level of the heart. There should be no talking at a time. So you as you can imagine, a lot of these are not obeyed during our routine checks. Importantly also is the calf size. So it's important that you measure the arm circumference, and then the length of your bladder has to be about 80% or more of the mid-arm circumference or the arm circumference, and then the width of the bladder has to be 40% or more. So if you've measured 40 centimeters mid-arm, then your length has to be at least 80% times the 40, which is around 32. So that is at least 32. So you can be at least a little over 32, and we are looking at the length being 36 here, and the weight has to be 40%, so that comes to around 16. So it's important that we select the right calf size for the arm circumference. These are some factors that influence the blood pressure. So if the calf size is too small, then it elevates the blood pressure spuriously as much as 40 millimeters mercury. If your back is not unsupported, your feet is unsupported, you can go as high as 8 millimeter variation in the blood pressure reading. Same for stress. If you smoke and if you kept a full bladder, that can also push your blood pressure up. So these are some subtle things that impact on blood pressure and make them somewhat unreliable, and making it important to at least do some home blood pressure monitoring, or where possible, ambulatory blood pressure monitoring as well. So as mentioned, the cutoffs are the automated oscillatory blood pressure or automated office blood pressure monitoring, anything 135 and or more than 85, and the observed or office blood pressure monitoring more than 140/90, which we have looked at. If you did a 24-hour and 130, then your awake ambulatory blood pressure more than 135 in that order. This will help you, tell those who have white coat hypertension. So they come to the office, you check the blood pressure, it is more than 140/90. But if you check, you use an ambulatory blood pressure, they are less than 135. So they are classified as white coat hypertension. Those who are truly hypertensive, of course, their blood pressures are more than 140/90, as you can see. And then if you did ambulatory, they are also above 135. So this the home and then the ambulatory blood pressure help you to categorize which one is white coat, which one is truly hypertensive, in that order. So the second commandment beyond the confirmation of blood pressure or screening of blood pressure is the opportunity to screen. So if you screen your blood pressure right now and the blood pressures are okay, less than 120/80, then at least you have time. You can repeat these readings every 5 years at most. If they are normal, that is between 120, 129, then you can repeat them every 3 years. If they are high normal, then you have to, that is, if you check this in the office, you have to be sure if it's maxed hypertension or not. So then you can do your out of office blood pressure readings, where you can do an ambulatory blood pressure monitoring or home blood pressure monitoring. If you're truly hypertensive or more than 140, then you can repeat them at subsequent visits or still do your out of office measurements to confirm. So these are the ESC guidelines: normal less than 120, optimal less than 120, I should say, normal between 120, 129, high normal 130, 139, grade 1, grade 2 in that order. Comparing this with the American Heart Association, their normal is less than 120 as well. But when you do 120, 129, they consider you elevated. So their threshold is a bit lower for you to be termed or labeled elevated. And they have stage 1, stage 2 compared to ESC that has grade 1, grade 2, grade 3 in that order. Okay, so when do you have to start treatment? The American College of Cardiology will want you to consider treatment if you're doing anything 130, 80 or more. The European Society, as we've seen, if you're doing anything 140, 90 or more. Then the third commandment is office blood pressure threshold for drug treatment. So clearly, if you measure the blood pressure and you're doing high normal, then lifestyle, as you can see, cuts across, is the backbone of all treatment. So lifestyle is important. But if it's high normal, then you could consider drug therapy if the patient has very high risk factors. This patient is also diabetic, maybe has some peripheral vascular disease, or has even coronary artery disease, and this patient is a high risk, then you may consider treatment directly. So if it's grade 1, between 140, 159, still lifestyle is important. You can still start treatment if the patient is again very high risk, in that order. Fourth commandment is to be careful among the patients who are not yet on treatment, who are frail and are aged. Then you are looking at considering treatment if the systolic blood pressure is anything more than 160 over 80. You want to be careful that in the elderly, particularly those who have never been diagnosed hypertensive, you don't push blood pressure down too low. So the threshold is higher if you are aged. How low you should go, or again, they are targeting anything less than 140, and as far as tolerable, if you can do you are less than 65 years, you can hit the blood pressure or lower it less than 130. That is okay, as long as the patient is not symptomatic. There's some evidence that if it goes too low, the patient may have some side effects and symptoms, and we should bear that in mind. Sixth commandment is that lifestyles are still a cornerstone. Then the seventh commandment is start treatment in most patients with at least 2 drugs, not one. So it used to be just one drug, but the guidelines are endorsing this single pill strategy to treat hypertension. As you can see, is a preferred strategy. The reasoning is that the number of pills is directly related to poor adherence or compliance. So if you're going to put a patient on 2 or 3 separate free medications, chances that a patient will take all of these are low compared to if you just did one. So what are the options in terms of the armamentarium of options that you have to choose from? So thiazide, like diuretics, ACE inhibitors, ARBs, long-acting calcium channel blockers, beta blockers, and then a single pill combination. So clearly, initially, if blood pressure is up, the guidelines allow you to do some dual combination or combination therapy. The question is, if this patient is not doing well, then you can go upscale to a triple combination therapy. If it's resistant, there are other options like adding spironolactone or mineralocorticoid receptor antagonist. So it's important that the guidelines have been simplified, and we know what the preferred therapy is, which is a single pill combination therapy. Again, patients don't just have hypertension, they may have other cardiovascular risk factors like dyslipidemia, diabetes, which have to be managed concertedly. So as a matter of fact, as you are managing the high blood pressure, you are estimating and assessing the cardiovascular risk, and to give medication that will have impact on those cardiovascular risk factors as well. So the European Society of Cardiology looks at the stages and the grades as you see here, and they also look at the number of risk factors and whether there is evidence of hypertension mediated organ dysfunction, and that puts you in a very high risk category, and you have to look for those risk factors and address them accordingly. The World Heart Organization guideline that came out in 2021 also alludes to and is consistent for the most part with the other guidelines we've looked at. So clearly, these are the 10 commandments that have been endorsed by the guidelines as we have seen. The question now is we need to focus on what the new strategy is, which is a single pill combination therapy is preferred, because as I mentioned, you have the opportunity to start medication at very low doses, and again, you have opportunities not just to lower blood pressure, but to also deal with other risk factors that may be present in such patients. So clearly, there's a difference between the 2013 guidelines and 2018. So initial combination therapy in the past was not highlighted, but in 2018, it's received a class 1 indication. Single pill combination is the evidence for that was weak in 2013, but in 2018, this evidence has gone to class 1, which is a very strong evidence. So it's important to consider the fact that cardiovascular disease or cardiovascular risk is a continuum. So the other arms or aspects of managing the patient should also be seen as that kind of continuum, so that we are very clear about that if you take cardiovascular continuum, for instance, hypertension can come in, starts uncomplicated, it gets it produces or results in hypertension mediated organ dysfunction, and then this kind of dysfunction can then become symptomatic or not. So it's important to give medication that would have effect on this whole continuum. So they may start with just hypertension, atherosclerosis, but they may end up with heart failure. Same in the management continuum. It's not just the optimal treatment that we are interested in. We are also interested in patients' adherence, because that would impact on the outcome and the maximum benefits we'll get from that treatment. So physicians have to be proactive. One of the ways that physicians have shown inertia is in the diagnostic or the diagnosis of hypertension. Failure to diagnose hypertension properly or reveal uncontrolled treated hypertension. So we must assess our patients very well and be able to assess whether they are controlled or not. In the area of therapy, we fail to initiate or escalate treatment. So that's one of the ways that we've shown a lot of clinical inertia. We fail to detect adherence or non-adherence, for that matter. We fail to even choose from the best available evidence of evidence-based medicine. When it comes to the management continuum, it's important that we ask ourselves, is the BP controlled? Is the patient tolerant? Then continue. If the BP is improved, patient is tolerant, however, but we are not on target, then it's important that we escalate or we improve the care. If the patient is not tolerant, we must modify. And in this case, we're advocating, and the guidelines are supporting that we advocate single pill combination therapy. If the patient is poorly adherent, there's room for motivation. So what's the ideal single pill combination therapy? It's useful in various clinical conditions. It's useful in different age groups. It's available in various combinations, and it's supported by evidence-based. If you take the 3 combination of indapamide, perindopril, and amlodipine, clearly you can tell that you have a drug whose action or peak action starts around 1 hour. Perendopil will take over 3 to 6 hours, and then amlodipine will take over. So clearly, within a 24-hour period, you have medication that will complement each other's effect. So making the room and the case for single pill combination therapy, triple therapy for that matter. Perendopil is the most studied ACE inhibitor, providing consistent morbid mortality benefit beyond BP control, as evidenced in all these trials. In indapamide, there's a efficient trial that has shown that patients who had grade 2, grade 3 hypertension who were put on indapamide and amlodipine, they did well compared to just calcium channel blocker. Same for advanced Hypertension and ASCOT trials. So why triple combination therapy? There are about 40 or 45% of individuals who are unaware that they are hypertensive. Again, if you look at the famous SPRINT trial that is making the case for the lower the better, you can tell that 56% of the patients were on at least 3 or more medications. So the benefit largely that was touted by SPRINT trial is, if you like, mediated by patients who were on triple therapy. Combination treatment is important. You can tell here that only 20% of patients were controlled on monotherapy. If you come to dual therapy, 40 to 60% of patients were controlled. Clearly, if you are on 3 or more, you are controlling your patients, or you are driving your patients towards target in 80 to 100% of cases. So most patients are not controlled on just 2 drugs, as you can see. Most patients, from all these studies, most patients are not controlled. So it's 3 or more that is doing the trick. So why not then go for medications that will do this control? So 8 out of 10 patients need multiple medications. What drugs? All the guidelines from European Society Cardiology to WHO are endorsing the use of RASI or RAS inhibitors, which could include ACE inhibitors and losartan and angiotensin receptor blockers. All the guidelines are endorsing RAS inhibitors, calcium channel blockers, diuretics, and beta blockers, as the case may be. So those are the options, at least for the first line medication. You can tell here too from all these meta-analysis that ACE inhibitors are doing better in terms of controlling hypertension if you compare to ARBs. For most of the studies that have been published, ACE inhibitors are doing the trick as well. If you come to the diuretic, thiazide-like diuretics, you can tell that if you compare your indapamide to your hydrochlorothiazide, indapamide is doing better, and hydrochlorothiazide is less potent over here. Same here, if you compare clothalidone to hydrochlorothiazide, it favors clothalidone in terms of benefits. Now, it has happened also because of the effect on metabolic profile. So if you look at the effect of different diuretics on metabolic profile, if you look at the green, which signifies indapamide, you can tell that it's doing the minimal changes in serum potassium, minimal changes in serum glucose, and minimal changes in serum uric acid. So if you do indapamide, for instance, you have very little perturbations in metabolism. Same for the pianist study and the Petra study. These are all real world data. So like basically observational data. Patients who were put on these medications, perendopro, amlodipine, indapamide, and they were monitored 4 months after and 3 months after, as you can see. These were the other benefits that their metabolic profiles showed. So there was reduction in their total cholesterol, uric acid reduction, and a very little effect on sodium potassium. Real world data. Same here for secondary analysis of the Triumph randomized clinical trial that used telmisartan and ARB, and it also showed some benefit. What kind of patients? So clearly, triple therapy can be used across all grades of hypertension. It can be used when it's compared to just ACE inhibitor, and you assess blood pressures at baseline 1 month and 4 months. It favored the single pill combination therapy, which is in white, if it's compared to ACE inhibitor, if compared to ARB, compared to dual therapy, clearly the triple therapy is tops. Same here for percentage of control. If the patient was on the triple therapy, clearly the control gets better. That is the one in red once you switch them to triple therapy. Again, the ASCOT trial looked at patients who had various cardiovascular risk factors, but did not have overt endpoints of cardiovascular disease. So they included diabetics, people, smokers, LVH, people who had left ventricular hypertrophy, and that order. And clearly, the MACE events in these patients were reduced in the proportions that have been shown. So clearly, beyond the BP control, there is benefit in major adverse cardiovascular event. Again, one of the benefits of single pill combination therapy is the less blood pressure variability or variation that it impacts on the control. In terms of starting single pill combination therapy, there is evidence to show that if you start them early in treatment, they are in the journey of treatment, they are able to reduce your cardiovascular outcomes, particularly stroke and other MACE events. This paper, which showed early cardiovascular protection by initial 2-drug fixed dose combination therapy, single pill combination therapy showed that after 1 year, there was benefit in favor of combined therapy in terms of reducing coronary events, ischemic heart disease, stroke, heart failure, all favored combination therapy. Adherence was also improved. As you can see, after 1 year, adherence is improved. And once you're doing single pill combination therapy, for the most part, price goes down and also is beneficial to the patient finances. Again, death and cardiovascular events are reduced. So we need to simplify our thinking and go for single pill combination therapy where the case may be. Indeed, it's effective to treat to target. It has advantages beyond blood pressure control. Benefits are first line or initial treatment. It has reliable efficacy in high-risk patients, and it's a single shot with the best option of medication. Again, there are positive results from real-world data. Thank you very much for your attention.
Thank you so much, Dr. Lambert, for such precise and insightful presentation. Thank you. I believe we'll take the questions at the end of the presentation.
Welcome.
So to take us through the next session, which is on the concrete clinical case of a Black hypertensive patient uncontrolled on dual therapy, is a fellow in cardiology of the West Africa Central of Physicians. She has her postgraduate training in interventional cardiology at the Guangdong Cardiovascular Institute in China. So, ladies and gentlemen, I present to you Dr. Abba Folsen, a senior lecturer and a consultant cardiologist at the University of Health and Allied Sciences. So, Dr. Abba Folsen, the platform is yours. Thank you.
Thank you very much, Zadia, and thank you very much, Xavier, for this opportunity to share a few thoughts on hypertension, and particularly difficult to treat hypertension. And thank you, Lambert, for setting the tone the way you have. It makes my work very easy because it puts across all the reasons why this particular patient that I'm about to present was managed the way he was managed. I put in a few slides just as a way of introduction, but I'll skip most of them because I think that Lambert has done justice to all of that. Right. So the problem with hypertension has already been elucidated. My slides are not moving, please. Can I have control of that, please? Thank you. So there are several factors that Lambert mentioned earlier on that makes hypertension a big deal in our setting. We have social and scientific factors. I think I wanted to mention a few of them because they play an important role in our care of patients with particularly difficult to control hypertension. First, there are the stresses that we are exposed to, especially in our part of the world, financial issues, psychosocial issues that just foster uncontrolled hypertension. But beyond that, hypertension in Black patients are a little bit special in that it's been found through a whole lot of data that there's overexpression of certain receptors, the endothelin-1 receptors that foster vasoconstriction, therefore increase peripheral resistance, particularly in our setting. And there's also chronic sympathetic overactivity. I actually found out that if you look at two cohorts of children playing a video game, Black children and then Caucasian children, there's a significantly elevated blood pressure in the Black child compared to the Caucasian child. And that's just how much sympathetic activity can have or influence on our blood pressures. There's a reduction in the expression of nitric oxide, which affects vasodilatation, and that, of course, will impact on your blood pressure. That having been said, there are weightier matters regarding salt and its use in the Black population. Salt is an integral part of our diet, and we are particularly sensitive to it as far as our blood pressures are concerned. And there are slightly higher elevations in our blood pressures when we take in salt compared to when Caucasians take in salt. So having said that, salt has its role to play, receptors have their role to play, but what about the renin-angiotensin-aldosterone system? All these years, it's been said that Blacks are not are low renin population and therefore don't respond too well to the effects of ACE and ARBs. And in previous guidelines or now outdated guidelines, a lot of emphasis was placed on other medications for use in blood pressure control against renin-angiotensin-aldosterone inhibiting medication. The paradigm has changed over the last couple of years, as Lambert presented in the guidelines, that it's become an integral part of our management, not just because of blood pressure reduction, but also beyond blood pressure control. We need to improve on morbidity and mortality. We need to improve on or reduce the risk of getting hypertension-mediated organ damage, and the ACE and ARBs play a very important role. But having said that, the fact remains that we have reduced efficacy of ACE and ARBs on account of ethnic variations in the way we metabolize and activate the drugs. That having been said, it's also true that genetic mutations resulting in baseline sodium retention can lead to naturally low renin levels because we eat a lot of salt and the RAS system ultimately affects salt absorption. There is reduced stimulation of renin in us because we have an okay baseline level of salt and water. That kind of suppresses the stimulation of the RAS system in us. So if you have a drug that is going to act by inhibiting the RAS system, then if your levels are low, then theoretically, the impact of these drugs on your blood pressure will not be as high as it would be in other higher renin populations. Having said that, ACE inhibitors and ARBs remain, as I've said, widely used in the management of hypertension in Black patients, despite all of this, because like I said, the benefits go way beyond controlling the blood pressures to impact on all the major organs in the body, and particularly the heart. Therefore, it's important that clinicians should understand the role of therapy in ACE inhibitors and ARBs in our population, and that they still play a very vital role. Dr. Apia showed this slide earlier on. I just want to reiterate just a small bit of it about pharmacotherapy in our patients with hypertension, and the fact that normally or in the past we would have started one drug, when you found a hypertensive patient, increased the dose to its maximum limit before adding a second or a third drug. And that was nicely captured when you talked about inertia in the physician. Sometimes the patients come with all kinds of stories. They didn't take their medication a few days earlier, they didn't rest well, etc. And all that fuels the inertia to optimize therapy. But the guidelines are quite clear that if you're managing a patient with hypertension and as at the time that you're diagnosing them, their blood pressures are 20/10, systolic, diastolic, respectively, above the target you are hoping to achieve, then they probably will not do well on just one drug. And it is a recommendation to start them on 2 medications right from the get-go, and preferably as a single pill combination. So to make it a bit more real, if you have a patient that you're diagnosing to be hypertensive with a blood pressure of 162, 102, and the target you're hoping to achieve is 130/80, and this patient is way above the target that you're hoping to achieve, and starting one drug will not do the trick as far as optimization of their BPs are controlled. I think the fact also remains that drugs have a synergistic effect and they potentiate the action of each other. So it is generally better to put 2 different drugs with 2 different mechanisms of action together. You're more likely to achieve target than to put the patient on maximal dose of one. Not to mention the impact on side effect profile, which are also enhanced with higher dosing. So I think Lambert has already made the point that basically 2 drugs are recommended for most patients, because for most patients, their blood pressures as at the time of diagnosis will be way higher than the target for which you are treating them for you to use just one drug. In Black patients, generally it is preferred, as in most of the guidelines, to start with a combination that involves the use of a long-acting CCB. And again, he mentioned it, and I'd like to reiterate the fact that long-acting calcium channel blockers are preferred definitely over the short-acting ones for obvious reasons. And it would be good to start in Black patients a drug combination therapy that contains either a calcium channel blocker that is long-acting or a thiazide-like diuretic as an initial therapy. But because most patients will require dual therapy right from the get-go, and preferably as a single pill combination, drug combinations that use a calcium channel blocker or a thiazide-like diuretic combined with an ACE or an ARB tend to be quite suitable and effective in Black patients, as I will show in my case presentation. As Lambert already mentioned, and I've tried to put it here, single pill combinations are definitely preferred to enhance the compliance of patients. I'll tell you a funny story. So, and this is personal because it's my dad. But my dad takes a couple of medications, and my daughter came and asked him when he saw his nice cohort of medications beside his cup of tea, whether he was having his meal or his pills for breakfast. Wasn't he having standard breakfast? Is this going to be his breakfast? Because he saw a whole stack of different pills. Having said that, those were not all antihypertensives. He's on medications for other things. But the point remains that unless a patient is highly motivated, the pill burden plays an important role in their compliance and subsequently in their outcomes as far as hitting targets and preventing, more importantly, preventing the development of hypertension-mediated end organ damage is concerned. So if you can reduce the pill burden for a patient, I think that it will go a long way in the success story. So with all that information, I'm presenting a 42-year-old male, Mr. AB, that I was personally involved in managing. He was a known hypertensive 5 years prior to presenting to us, not diabetic and not obese, and no other significant risk factors of note. He is said to have been compliant on extended release nifedipine and had been largely regular with his reviews until he presented 6 hours. We presented with severe headache and left-sided weakness 6 hours prior to us seeing him. On examination, his blood pressure at presentation was 250 over 125 millimeters of mercury with an MAP of 169. His other vitals were largely stable and he was not in heart failure clinically at the time. His chest had transmitted sounds, breath sounds were vesicular, and no crepitations were heard. On the central nervous system, his GCS was 13 of 15, his neck was subconcanex was negative. The power was 0 in his left upper and lower limbs. Tone was normal at the time, his reflexes were equivocal. And additionally, he had left-sided abducens nerve palsy and a lower motor neuron facial nerve palsy as well. The diagnosis in the emergency room by the emergency physicians was CVA with left hemiplegia, left 6th and lower motor neuron 7th nerve palsy, secondary to uncontrolled hypertension. They also wondered whether the patient had aspirated. After an initial primary survey, the patient was started on standard IV labetalol infusion, 0.1 milligram per kilogram per hour. An NG tube was passed and was also administered oral medication in the form of ramipril 5 milligrams and nifedipine 5 milligrams twice a day. I think initially they had passed the NG tube because they suspected that the patient had some swallowing difficulty, and in order to prevent worsening of the chest findings, they passed the NG tube. And they also chose plain nifedipine. I think also, I can only assume for them that they were thinking about denaturing the extended release nifedipine if they crashed it through the NG tube. They did this for just 24 hours and achieved a blood pressure average of about 190 over 120, which was still not optimal, even though the recommended 20% reduction had been achieved. The patient had some cardiomegaly on his x-ray, and the chest on x-ray seemed largely okay. His ECG did not show any evidence of ischemia. Some left ventricular hypertrophy was noted. The CT scan showed a hemorrhage with perilesional edema in the left hemisphere with some compression of the ventricles as well. His echo done at the time showed moderate concentric left ventricular hypertrophy, which suggests that he has been hypertensive for a while. His left ventricular systolic function was adequate. He had some moderate relaxation problems, but at the time, his right ventricle was functioning well and he had no pulmonary hypertension. So subsequently, the patient remained okay. He was still maintained on nifedipine 40 BD. Ramipril was increased to 10 and idapamide was added at 1.5 milligrams. The limitation, again, I said, was that this patient in particular, after the NG tube was taken out and he was given oral medication, had a knack of chewing his antihypertensives for no clear reason. So initially there was a lot of erratic blood pressure records, high values coming down intermittently. And so after counseling him and encouraging him to swallow his medications instead of chewing them, his medications were also changed to a longer acting calcium channel blocker, as we have already said, and which Lambert mentioned earlier on, to maintain some predictable pharmacokinetics as far as the drug was concerned. And also patient was changed to perindopril 10 milligrams daily, and this was given to him as a single pill combination. And as is expected, because the absorption of this became more sustained and more predictable, the patient achieved further blood pressure reductions, plateauing at about 170 over 100 after that change was made over the next 72 hours. Over the next couple of days, the patient improved steadily. To achieve even better control, the patient was put on a single pill combination of 3 medications comprising perindopril at 10 milligrams, amlodipine at 10 milligrams, and inapamide as 2.5 in a single pill combination. And over those couple of days, the patient did remarkably well. BPs remained a target of less than 140 over 90, for which we were all very happy. Unfortunately, a few other complications, which are not the focus of my presentation for today, but which I thought I should just mention, occurred. He was noted to have a unilateral leg swelling and subsequently developed significant difficulty breathing, low saturations. His BPs crashed all the way to less than 90/60. The venous Doppler showed extensive deep vein thrombosis involving all the deep veins of the left leg, and the CTPA was indicative of a pulmonary embolism. Of course, at that point, all his antihypertensives were stopped, and the patient was optimally managed for pulmonary embolism, including the insertion of an IVC filter because he had had an acute bleed a couple of days prior. As the days went by, the patient recovered nicely from the. Oh, I forgot to mention that his repeat echo done at the time showed mild dilatation of his right side cardiac chambers and some moderate pulmonary hypertension, even though his ejection fraction still remained good at the time of the repeat echo. So after the drama of the pulmonary embolism, the patient recovered, his vitals improved nicely, the pulse rate settled down, and of course, as is to be expected, his blood pressures began to creep up again. The point I want to make at this point is that even though he had required 3 medications at the time to control his blood pressures, we restarted him on his medications in a graded fashion, So when his blood pressures got to about 150 over 80, we started with one drug. We started with the long-acting calcium channel blocker. And as the days progressed, we added on the ACE inhibitor and subsequently the thiazide-like diuretic. So by the time it was about day 43, which was a couple of days ago, the patients were doing quite well on single pill combination comprising perindopril, amlodipine, and indapamide. And that was all he required to keep his blood pressures maintained nicely at 134/78 as at 3 days ago when I last saw him. So to conclude, I want to mention a few points on my 4-point fact sheet. And the guidelines acknowledge that the majority of hypertensive patients, including Black patients, will require more than one medication to control their blood pressure. And we don't want to, as physicians, show inertia in initiating treatment pharmacologically and non-pharmacologically in our attempt to achieve better blood pressure control. The point is also very clear that long-acting medications given as single pill combinations have synergistic effect and less side effect profile, thereby enhancing patient compliance and ultimately their outcomes. We saw that very clearly in this patient who was initially on short-acting medications as multiple pills and was having a hard time controlling his BP. In Black patients, initial calcium channel blocker or diuretic therapy is particularly effective, but only if the patient requires monotherapy. I'd like to reiterate the fact here again that most of our patients, however, will not do well on monotherapy, considering the targets that they are to achieve and the starting blood pressures at which we make the diagnosis. So with that in mind, RAS inhibitors have immense benefit in combination with the standard initial therapy in Black patients that go well beyond blood pressure control into organ dysfunction or into improved outcomes of our patients, even in Black patients who are perceived to be low renin patients. If there are any questions, we'll take them now, and I'll end my presentation here. Thank you.
Hello, everyone. So my name is Cecilia Kisi, and I am a pharmacist with Servier. And I'm going to wrap up this program with a presentation by Servier, and I'll focus on the tailor-made offer that Servier has for your hypertensives that are uncontrolled on dual therapy. So the solution we have, as Dr. Fossey mentioned, is Triplexam. Triplexam is the triple therapy for more power. Triplexam consists of the ACE inhibitor perindopril, the calcium channel blocker amlodipine, and the thiazolide diuretic indapamide. So in my next couple of slides, I'm going to throw light on the individual molecules and how it makes perindopril Triplexam a powerhouse for managing your hypertension with needing triple therapy. So I'll begin with Corvasil, the ACE inhibitor bit in Triplexam, and the generic name is perindopril arginine, but on the market it is branded as Corvasil. Corvasil is the most lipophilic ACE inhibitor, as we can see from the graph. What this means for us is that we know that the ACE enzyme, there's 90% in the blood, and then 10% in the blood and 90% in the tissue. And so if you have high lipophilicity, you're able to cross the phospholipid layer and inhibit the tissue ACE. And this leads to a strong blood pressure reduction. And therefore, you will have a higher blood pressure reduction with Corvasil, coupled with an increased vascular selectivity and a 24-hour blood pressure control. And the 24-hour blood pressure control is due to the trough to peak ratio, which has been illustrated on your right. This is the trough to peak ratio of the various RAS inhibitors, spanning from the ACE inhibitors to the ARBs. The trough to peak ratio indicates the efficacy of the drug in a 24-hour period. This is very critical for early morning strokes and heart attacks, especially between the hours of 4 to 8 a.m. So you realize that for some companies, they would tell you to let the patient take the drug in the evening. But if you have a full 24-hour coverage, there's no need for you to be choosy about what time to take the drug. So because Corvasil has a high trough to peak ratio, amlodipine has a high trough to peak ratio, and indapamide has a high trough to peak ratio, it gives Triplexam a very long-acting effect for your patients. In addition to what the base molecule Corvasil can do for you, the previous slide focused on the characteristics of Corvasil, and so this characteristics must sure translate into morbid mortality studies. And so this is a summary of all morbid mortality studies that has been done for all the RAS inhibitors as they were being discovered from inception. So you realize that the top ones, the colored ones, are the positive trials that met the endpoints, and the down ones are the negative trial. As it stands now, Corvasil has become the reference of the RAS inhibitors because it has 6 morbid mortality trials that it can boast of all across the cardiovascular continuum. Pre-Mai talks about the fact that Corvasil is able to regress LVH. Progress is preventing a secondary stroke. Europa is preventing a secondary event of a coronary artery disease. Hybert is preventing stroke in the elderly. Advance is preventing cardiovascular events in your hypertensive diabetics. And then Ascot is preventing cardiovascular complications in your hypertensive with 3 risk factors for coronary heart disease. So having spoken about Corvasil, I will just zoom into indapamide, the superiority of indapamide. And this comes from the fact that it has a high BP lowering efficacy as compared to the other thiazides, like the hydrochlorothiazide and then the clothalidine. It also has a 24-hour blood pressure control, like I showed you from the trough to peak ratio graph. It's also been shown to give you cardiovascular protection from heart failure and then stroke. One of the major side effects of the thiazide diuretics are the metabolic issues, but indapamide has shown to be metabolic neutral. So you don't have your typical effects of hypercholesteremia, hyperglycemia with indapamide. Of course, amlodipine being the third molecule is widely used, and we all know the efficacy of amlodipine. And so having combined these perindoprol, indapamide, amlodipine, and triplex-am, and looking at the characteristics of the individual molecules, it gives triplex-am a powerhouse in managing your hypertensives, mainly centering on the blood pressure reduction and the cardiovascular effects. And so this is to show you the powerful blood pressure reduction that when you initiate your patient on triplex-am, you would get. And I'm really happy that Dr. Fossey has presented a case that truly has reflected this drop in blood pressure. And so averagely within 3 months, you can get as high as 54 millimeter drop in mercury for your patients when it comes to the systolic, and then 19.6 millimeter mercury for your diastolic. So for a patient like hers that she presented, subtracting 54 from their initial BP will take the patients to target goal. In addition to the strong blood pressure reduction, because of the individual molecules in triplex-am, which have the individual cardiovascular protection, it's also been shown to give you an unparalleled cardiovascular protection, total mortality reduction of 28%, as seen in the advanced CCB. One of the major concerns of antihypertensives is also about the side effects. So this is just a multi-center perspective of observational, non-interventional 4-man trial that shows a very good tolerance of patients to triplex-am with regards to cough, edema, and hypotension, which is are the major side effects you have with patients who take the ACE inhibitor. So you realize that even though perindoprol is an ACE inhibitor, because of its lipophilicity, there's a reduced side effect, as was depicted in this trial. So as I'm concluding, triplex-am comes in 4 varying dosages. So always the first dosage is the perindoprol, the middle is the indapamide, and the third is amlodipine. I'm sure we are all familiar with Natrolix as 1.5 milligram, but when it comes as a combination, it comes as 1.25 milligram. And so you realize that the lower dose of the perindoprol always matches with the lower dose of indapamide. The higher doses of perindoprol matches with the higher doses of the indapamide. And this is to balance the hyperkalemic and hypokalemic effects of the ACE inhibitor and the thiazolide diuretic. So you have 4 main options, which is 5 1.255, 5 1.25 10, 10 2.55, and then 10 2.55. So regardless of what your patients have been on previously, you just have to extrapolate the equipotent dose to what your patients will benefit from in triplex-am. And we have all these 4 dosages for flexibility of dosing. So for all your patients that are uncontrolled on dual therapy, in some instances, we've even seen patients uncontrolled on 3 or 4 medications that were given triplex-am and then the BP crowd. Look no further than 1 tablet of triplex-am, the triple therapy for more power for your patients. Thank you.
Thank you so much, Cecilia, for such brief and concise presentation. So we'll have our Q&A session now. However, just a quick reminder for us to take our post-test right after the broadcast is done. So this is the first question is from Dr. Kennedy. And the question is, are all ACE inhibitors the same? This is from Dr. Kennedy. I believe Dr. Lambert or Dr. Aberfolson can take this for us. Thank you.
I thought that this was a pharmacology question, and so the pharmacist would
Yeah.
I agree.
with what
But
we know about the medications at hand, I mean, they work differently. I mean, it's quite clear that the pharmacokinetics of ACE inhibitors vary, the pharmacokinetics of ARBs vary, and it is that determines their efficacy. Having said that, they would all bring down blood pressure to a certain degree, but to what extent, um, that varies. And there's a lot of data that is available. Some of them compared head to head, comparing blood pressure reductions among patients. So yes, they vary. And by that same extension, their side effect profile also varies. So yes, perindopril is different. And I think that perindopril would be different mainly because of its long-acting nature and the offer of a prolonged and sustained blood pressure control that it would offer. But I think that the pharmacist should add on to this one.
okay, so from Cecilia, over to you.
Okay, so like, thank you so much, Dr. Foster. I think you've laid down everything. What I would like to add is, yes, the ACE inhibitors are different in terms of their action. So you realize that the potential of an ACE inhibitor resides in its lipophilicity, and like I showed in my slide, depending on your level of lipophilicity, you're able to inhibit more of the tissue A's that leads to the strong blood pressure reduction. So the higher the lipophilicity, the higher the penetration, and then the higher the blood pressure reduction, and also the extravascular effect.
Yeah, and
Thank
I
you, from
mean,
Cecilia.
okay, just to add to it, I mean, they are all not the same. I mean, I don't think any two medications are the same at a molecular level or even side effects, profile. If you look, a lot of information will come from studies, as I'm sure Dr. Folson has said, and of all the ACE inhibitors, it's perindopril and ramipro that have been most widely studied in terms of reducing major adverse cardiovascular effects. And there is enough documentation to even say that perindopril is the one with the least cough-induced, or should I say, cough as a side effect. Maybe it will border on the lipophilicity, as you have mentioned, but they are all not the same. Class-wise, yes, we know what they will do in, preventing conversion of angiotensin 1 to angiotensin 2, but the side effects will depend on other things like the lipophilicity, as has been discussed.
Thank you so much, Dr. Lambert. Okay, I think Dr. Lambert has answered this. So, does perindopril have the same incidence of cough as compared to other ACE inhibitors? So, I know Dr. Abba Folson would like to add something to it.
There isn't anything else to add. I think it's been said that the side effect profile of this drug is very dependent on its action, and the side effect of cough is very dependent on its other actions and other receptors that it activates. And perindopril has the least of those actions. It stays focused on where it is supposed to act, and then therefore reduces the cough side effect, the release of bradykinin, etc., which lead to the cough that the patients have. So yes, I think the point is clear.
I think
Thank
Zadie,
you.
I would like to add something small to that
Yes,
with
please.
perindoprils. So we know that they've been linked, the effects of cough has been linked to the build-up of bradykinin in the lungs. Because the ACE inhibitors are not able to they prevent the breakdown of bradykinin. And you realize that at the lung level is more hydrophilic. So if you have an ACE inhibitor that is more hydrophilic, is able to concentrate in the lungs to produce the cough, which is typical of a lisinopril, which is very hydrophilic. The reason why perindople has a reduced cough incidence is the fact that because it's lipophilic, the affinity in the lung area is very minimal, and so its affinity is more for the kidneys and the heart, focusing on reducing blood pressure. So there's a lower chance of your patients coughing on perindople because of the high lipophilicity and its ability not to concentrate in the lungs.
Yeah, and I mean, just to add, the issue of cough in ACE inhibition is it's important. In my experience, I can say, and it's in literature as well, that for some reason, it's seen commonly in females. We don't know the exact reason, but I just want to add that before we conclude, or you conclude, that the patient's cough is due to the ACE inhibition, just be sure that this patient doesn't have any other cause of cough. There's evidence to show too that very simple over-the-counter medications, nasal decongestants, um, aspirin, NSAIDs, and stuff like that can induce cough in some patients. So you want to be sure that this cough is attributable to the ACE inhibitor before you take action. Sometimes just dose reduction or replacing it with an ARB may help deal with it, but we need to be sure that it's from the ACE inhibitor.
And also, maybe just to add to that point, because it is a very valid point, that these days patients read the literature, and they actually look out for these little things that have been written in the literature.
Yeah.
And sometimes the cough is really very negligible. So a little reassurance, and patients are okay. Um, you want to be sure that this cough is worrying enough to warrant a change in the medication, especially since the benefits of these drugs are enormous. So just because the patient has had a cough doesn't mean that the drug should be changed. The history must be re-looked at. Um, Reassurance given if the cough is really, really, really insignificant. Having said that, there should be a change made if it is that debilitating. Otherwise, the patient will just not take the medication.
Yeah.
Thank you so much, Farm Cecilia, Dr. Abba, and then Dr. Lambert. So we have some questions on YouTube as well. So from Dr. Al Hassan Salifu. So I think this is to Dr. Abba Folson. Please, with the case presentation, what was done about the CVA?
Oh, okay. So I didn't mention that because it wasn't the focus um, of my presentation, and I had just 15 minutes to present. So the mainstay of treatment of CVA definitely is to manage the risk factors. The chief one here being the hypertension, which we tried very hard to control. It was a hemorrhagic CVA, and not very much was directly done about that, as standard practice requires. We made sure that all his other end organs were intact. So his kidney was okay, his heart was okay, his eyes were okay. And when once we got over the blood pressures, physiotherapy, when once the blood pressures, got better, physiotherapy was instituted. The only new thing there was that when he had the pulmonary embolism, he was one of the lucky ones who actually got an IVC filter put in, because we couldn't do the doses of anticoagulation that we needed because the patient had had a bleed recently. And the patient is actually doing very well. He's been discharged, actually.
Okay. Thank you so much, Dr. Folson. So from Dr. Al Hassan, again, between the American Heart Association and the European Association, which classification does Ghana follow for grading hypertension?
If I may take a bite, we follow the European Society of Cardiology, and I think there is cardiovascular guidelines that have been compiled, and I'll take the opportunity to talk about it and to advocate that clinicians across the country can access these. They come in soft copies and hard copies, and then at least appraise yourself with the details of it. I think that we is classified based on the European Society of Cardiology. I mean, so at least you know that there is the optimal, the high, there's the grade 1, grade 2, grade 3. So that is what we adopt as Ghana cardiovascular guidelines. That's what I'd like to say.
Thank you so much, Dr. Lambert. I believe that's all. That's it for the Q&A session. Thank you so much. However, the platform is opened if you would like to give us some closing remark before. Okay, so sorry. There's a question here from Melvin Amwaku. Frimpong. So he says, wonderful presentation. Thank you so much. The question is, considering the financial status of most of our patients who largely rely on NHIS for their hypertensives, leave the question. Would it be okay to prescribe CCB plus ACE inhibitor plus thiazide as individual meds and strongly advise our patients to take them together at the same time in order to benefit from the synergistic effects a CPC therapy will?
Yeah, but if in our situation, really, if you cannot afford it, you can't afford it. But if it should not be left at that, I think my impression would be, as much as possible, the benefits of that single pill combination therapy should be enhanced for patients. I have no doubt it's Ghana that we are practicing in. People are heavily reliant on the NHIS. But I think that with the right amount of education and knowledge provision on the benefits of that single pill and its impact on compliance and outcomes, a lot more will be recruited onto single pill combinations. But of course, when you speak and they cannot afford it, they can't. So yes, the next best thing would be to do it that way. Having said that, I think the bigger problem here is that physicians are a whole lot reluctant sometimes to optimize medications and are very easily swayed by patients' comments on why the BP is high today and is not controlled today, and all those things. That makes the optimization of the care delayed when the patient will come in with that complication that we don't want. So let's not be inhibited in optimizing therapy. Let's push for single pill combination therapy. And if it cannot be afforded, then individualizing it, but making sure that we give it to obtain optimal control will be the best. Having said that, what's the status of Covasil and Triplexam on the NHIS, etc.? That's a question for CC.
Okay. Okay. Thank you so much, Doc. So currently, we are not on the NHIS domain. Yes. But of course, Sebia also thinks about the financial deficit that our country has. So as much as possible, we try to make it very affordable for our patients. And so, I mean, sometimes you have to also look at it from this angle. Buying the individual molecules as a single combination, as a single pill, sometimes together is even more expensive as the cost of just the one pill. And so, like I said, Sebia is very reasonable with pricing our products, and so you really have the value for money for your patients.
Thank you so much, Sisi. So I believe this is the last question from Dr. Charles Kekeli. Is it idealistic to use extended release CCB twice a day?
Lambert is looking in the sky. Once he's looking in the sky to come up with some data
Right.
he's hiding in there. I think um,
Well, you go ahead.
okay. With me, with my practice, I try to, as much as possible, go by what the data supports and what the evidence is for. And I have not reviewed too much data on extended release nifedipine. I have seen, however, quite an enormous amount of data on what amlodipine, which is a long-acting CCB, does. So, because I try to practice guideline recommended or guideline mediated therapy, I usually use amlodipine in my practice. Those who use nifedipine extended release, like Nificard XL, also think that it works, but I don't have the evidence to recommend that it be used. I can only speak for long-acting amlodipine, which I have used in my practice and also studied in the guidelines and found that it works. Maybe Lambert can comment a bit further.
Yeah, well, I mean, I don't think my answer is too different from yours. I mean, there are generics available, extended release, which is taken like twice a day, you know, and they will argue the pharmacokinetics out that, I mean, its effect will last about 24 hours and stuff like that. My concern is you have to look at the patient holistically and assess the patient's total cardiovascular risk. I always say that it's like eating food. You can eat junk and get full. You can eat healthy food and get full. But when you eat healthy food, beyond the fullness, it benefits the body. If you eat junk beyond the fullness, you actually get detrimental effect. So instead of fixating on just BP reduction, we look at drugs that will benefit blood pressure control and also reduce cardiovascular risk. And in that space, I mean, there's not much to be said about nifedipine in terms of reducing global cardiovascular risk. So we need to be clear the profile of the patient we are dealing with. Again, the guidelines are very clear that if you don't use short-acting nifedipine, because of all its rebound, tachycardia, and all the other side effects. Again, if you're going to use extended release high doses, some people actually dose 60 BD and 60/30. I personally don't do that because I don't find the evidence for that. And then the side effects that you put the patient through in such doses. So I think we just need to be clear. If we are interested in BP reduction, there are medications that we can add on to do BP reduction. And if we're interested in cardiovascular risk reduction, there are clearly guideline directed options for us to use. Thank you.
And maybe, thank you, Lambert. Just to add on, we've spent today, the past hour, talking about ways of reducing a patient's pill burden so that we can enhance their compliance. So I think if the option is there to take one drug that has long acting effects and which has been extensively studied, then I think that I would inch more in that direction than having to give this twice daily and all of those things. We should aim to make our patients' lives a little bit easier. It's not easy to be hypertensive, diabetic, in heart failure with dyslipidemia. I mean, the things you need to swallow can be a whole meal, and we should aim to reduce that.
Yeah,
Thank you.
I agree.
Thank you so much. Thank you so much, Dr. Lambert and Dr. Aberfolson, for such great and interactive presentation. So any closing remark from you, Dr. Lambert and Dr. Aberfolson?
Oh, I think it's been a very insightful, session. All I'd like to say is that um, there are real issues on the ground, and there's the evidence. The evidence is that if you reduce pill burden, compliance appreciates, and that would impact on outcomes. So for patients who can afford it, we should push for single pill combination therapy. Beyond the blood pressure reduction, there is cardiovascular benefit. Again, you make room for addition of other uh, medications, and the patient is likely to comply even with those other medications. The second point is that we should know that it is not just the idea of maybe combining into a single pill, but it is again bringing together um, 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 or attacking various mechanisms that are implicated in hypertension. So you are killing, if you like, two birds with one stone. I think I'll leave the rest for Abba to say for now.
Well, I think that Lambert has
Yeah.
nailed the bare necessities of this particular presentation. I mean, I don't want to have to be on antihypertensives, but if I end up on it, I would prefer to take one pill than to take three different ones. And looking at the way I work and the way I go up and down, it would be much easier in attaining compliance if I was swallowing just one. I think, having said that, my last words would be to my colleagues, the prescribers, that we should not be hesitant in achieving target. If you have a patient whose blood pressure is 180 over 110 and you bring it down to 160 over 100, you've done well. But the benefits that go beyond blood pressure control, which involve organ protection and prevention of HMODs, are best seen when you achieve target. So when you see your hypertensive initially and you start therapy, you must have a target that together with the patient in an evidence-based approach, you are hoping to achieve. And you must strive to achieve those targets. It's good that we brought it down to 160, 100. But it would be nicer if the target of 130, 80 that you set out to achieve, you achieve. Because it's at that point that the benefits are maximum. Thank you.
So much, Dr. Abba Folson. So I must say thank you so much, our esteemed facilitators, for giving us such insightful presentation. So to give us a conclusion, I'll call on from Cecilia Kisi. Thank you.
Hello, everyone, once again. So I'd like to use this opportunity to thank the facilitators, Dr. Baforsen and Dr. Lambert, for such an insightful presentation. And I also want to thank you, our esteemed doctors, for taking time off your busy schedule to listen to and to participate in this great CPD virtual presentation. And I hope that with everything we've discussed here, it will add on to enrich your practice as our prescribers. So I think after the meeting, immediately the posters will be available for you to complete and then redeem your CPD points. So Sevier also has triple exam available everywhere, right from right in Kumasi, Koforidua, Greater Accra region. It's widely available in 4 dosages. So in order to optimize the your patient's medication, you can choose triple exam for your patients needing a uncontrolled on dual therapy. Even in some cases, uncontrolled on triple therapy, triple exam has seen to really crack the BP. So we look forward to a nice experience of you using triple exam. and we are always available to help you and your patients locate it and help the patients throughout their journey with triple exam. Thank you so much and have a lovely evening.
Thank you so much, everyone. Enjoy your evening.